Great. Well, welcome everyone. My name is Stephanie Doyle. I am a senior associate at the Center for the Study of Social Policy and lead our work around the Pediatric Supporting Parents Initiative. I want to welcome you to our webinar today called Common Threads to Transform Everyday Practice. We know folks will be joining us in this sort of early moments of the webinar, but we thought we would get started because we have a packed sort of webinar to be able to share this work with all of you. Selena, do you want to go to the next slide? We wanted to start off by thanking the funder consortium of Pediatric Supporting Parents. This work is generously supported by 6 funders who have really worked hand in hand with us over the last 2 years to complete this project and to bring these findings to the field. So we thank them very much. So we wanted to start off by just sharing some objectives for the call today. This call is the first part of a 2-part webinar series that shares the findings from our recently released report. This report is really going to focus, this webinar is going to focus on the 14 common practices where we'll share what those common practices we discovered and provide examples of how we saw them implemented during the site visits that we conducted over the last year. This will highlight stories from staff and families and really hope to leave you with some practical ideas for implementation in your own setting and work. So just a quick look at our agenda. We'll give you some background about the PSP initiative, talk a bit about our common thread of relationships, and then dive into those common practices. And we're going to keep the most of the time for a panel discussion and discussion with all of you as we think about what this work means. So just a reminder that throughout, please share your questions so that we can keep track of them. There, you'll notice it's either at the top or the bottom of your Zoom screen, there's a Q&A button that you can click and submit your questions. And my colleague Selena will be monitoring throughout. And this is also something where we're able to share the answers and the questions with the entire group afterwards. So it's very helpful. And we wanted to share with you the 2 presenters that are joining us today, Casey Dudley and Dr. Kima Joy Taylor. Kima and Casey worked with us closely on the Pediatric Supporting Parents Program Analysis. Casey was a member of our Brain Trust of family members, and Kima was a member of our Pediatric Consultant Panel. And I want to just take a minute for Casey and Kima to introduce themselves.
I'll go first. Hi, I'm Casey Dudley. I work for the SPAN Advocacy Network in New Jersey. We are the Parent Information Center, but I am also a parent of a young boy that is 7 years old who has autism. And it was really a great experience to kind of do this work and bring the parent perspective to the table.
Hello, sorry. My name is Dr. Kima Taylor. As Stephanie said, I too was really honored to be a part of the team. Pediatrician by training, have live outside the DC area and have worked both on the ground providing care and also on the Hill and within the health department, and really focus on expanding access to services for all in a culturally effective way and a deep desire to reach health equity.
Thank you. And we'll be hearing more from Kima and Casey later. We thought it would be very important to bring both the parent and a pediatrician perspective to the call, as it was invaluable throughout our process. So we also wanted a chance to hear where all of you are coming from. So we're going to do a quick poll so that we can learn a little bit about your perspective. Selena's going to launch that poll. So if you're able to, please let us know who you are. What is your perspective that you bring to the work? So it looks like we've got some program implementers and program developers, some providers and funders, 2 parent leaders, and a whole lot of others. So we'll have to learn more about who you are. as we go, and you can always share in the chat who you are to the group. Okay, so I think we can close the poll. Thank you so much, Selena. And so it's really, I think that we'll be able to share a lot of what we learned from, there will be valuable lessons for all of these different perspectives as we go through the webinar. And again, look forward to learning more about who the other is along the way. So Selena, do you want to go to the next slide? So I'm going to actually pass it over to Selena now to give us a little bit of background about our work in the program analysis.
Hi everyone, thanks for joining. My name is Selena Chavez. I am a program research assistant at the Center for the Study of Social Policy, and I was involved with the PSP program analysis basically since it really started a couple of years ago, and have been through it all the way from the beginning, which we'll talk a little bit more about what it is, but really excited to see the work kind of wrapping up and moving forward and thinking about where it's going to go next. So basically just going into a little bit of a background of the PSP program analysis. The purpose of it was to study what is done and what may be possible in the pediatric well visit for children specifically ages 0 to 3 and the pediatric primary care setting to promote social emotional development in the parent-child relationship. And so what we here at CSSP did was that we really wanted to, it was called a program analysis because it was that we looked at different programs that were in the pediatric space or kind of adjacent to it in the pediatric setting. And we wanted to learn what was being done in those programs to be able to take those kind of common elements and think about how they could be scaled and applied more widely. So a little bit of background about how we got there. We wanted to really do a comprehensive review of the programs that were out there. So we went and looked at these databases, the registries of programs that were related to social emotional development, to parent programs, to child programs. And we actually, before we were reviewing 70, there were hundreds that we reviewed in general, but 70 was kind of the number of ones that seemed really relevant to our work that was related to social emotional development, parent-child bond, and parent mental health. So this was identified through literature, through registries, and we also did a nomination form as well, just to capture programs that maybe wasn't necessarily really available, maybe more homegrown programs. And that was really exciting because we got to learn about so much in many different settings. But of course, there were some limitations to this. Maybe there were some other programs that we missed. You know, we can't know everything and there was already so much to begin with. But we did really wanted to get a diversity of programs, what their goals were and what different settings and different geography and such. So we ended up choosing 12 different programs and conducting 13 different site visits around the country, and the next slide will show where. And these were on site visit teams that included 2 CSSP researchers, a family leader, for example, Casey went on a couple of our visits, and a pediatrician. And so we have Casey and we have Keem on this call, which we're really lucky for, but we also had a bench of other parent leaders, family leaders that really helped us out, both on a brain trust, which we consulted with throughout, and as that visited us and joined us on the site visits separately from the brain trust. And then we also had a group of wonderful pediatricians who assisted us throughout the project, the research, everything, but also on attending the site visits. And not only did we do these site visits, but we also had this convening, and you can kind of see the pictures over here. The top one is all of the family leaders as well as the CSSP core team. And we had the pediatricians, the program developers who we had been talking to, implementers, people that we met on the ground, and also, of course, family leaders, as I mentioned. And then as I kind of alluded to earlier, we had 2 advisory groups, one a brain trust of family leaders who we consulted to regularly throughout the entire project about the site visits, but also about the analysis and what we learned, and then the same thing with the group of pediatricians. And so this is just the programs that we ended up visiting. As we mentioned, there were a lot more that we viewed, and there's also a lot more that we wished we could have visited. But this is what we ended up as. We visited these 10 programs on the top here in different sites. Several of them we were able to do in multiple locations. For example, Healthy Steps, which we saw in one rural location in Sholo, Arizona, and then another one in New York. And so with these programs, we really wanted to get a variety of programs, what they were aiming to do, the different kind of tactics that they used, the different strategies that they used. But we also we tried as much as possible to get a little bit of diversity in terms of geography, where they were located, but also trying to get a couple of rural locations, not only urban, suburban. So we had a variety in that. And then the ones at the bottom, unfortunately, we had them on our list for as really outstanding programs, but because of logistical issues, we weren't able to physically visit them, but we did still conduct interviews with them to learn about those program components. And if you have any questions about that, just let us know. But I will pass it back to Stephanie for what we learned during these site visits.
Yes, please do put your questions in, and Selena can follow up with any questions you might have about how we approach the project, as well as we have a selection memo that describes all the programs that we looked at and what we learned from that initial search. But now I want to talk a little bit about what we learned through all of that work that Selena described. So when we were out in our visits and researching projects and programs and talking with stakeholders, we were really trying to learn about the common practices, not only in that experience that the family has with the care team, but we also really wanted to learn about the policies, protocols, partnerships, and infrastructure that supported effective implementation locally and allowed them to promote the social emotional development and parent-child relationship. It was really exciting that ultimately we came to 14 common practices that we really saw sort of organized across 3 action areas. So nurturing the parents' competence and confidence through those direct interpersonal and culturally responsive interactions with families around their children's social emotional development and their relationships. Connecting families to additional supports to promote healthy social emotional development. So those things that all families of young children can benefit from in their communities, as well as address stressors when they arise. And finally, we really saw very common across all of those visits, strategies that really worked to develop the care team and clinic infrastructure and culture so that they had the backbone and foundation to really implement these innovative programs and practices and facilitate trust to do so. Next slide. So as you can see, the 14 practices sort of organized across these 3 areas. And you'll notice on the bottom that we definitely, from very early on in our research, identified a common thread. That strong, strengths-based, trusting, and humble relationships among and between parents, the care team, and the community are essential. Throughout our visits, we often heard that theme, talking about relationships, talking about really specific ways that those relationships were put into practice. So you really saw relationships within that well visit as really being thoughtful about how they develop those relationships with families, but then how critical it was amongst the care team that they be able to work well, collaborate, and communicate with one another, and how important those trusting relationships were there as well as care teams introduced new members or were working around supporting a family who may have extra needs. And finally, those relationships extended into the community because it was important, particularly when working around social emotional development and the social determinants of health that might be impacting families. It could not end at the clinic door, and those relationships with community partners were incredibly important, and also thinking about relationships for families to other families within their community that could support them in between those visits. Next slide. And I think this is an amazing quote from one of the family members on the parent brain trust that really, I think, drives this home, this importance of relationships. A physician doesn't necessarily need to look like you, a parent, in order to build a connection and relationship, but they do need to see you as a person, recognize your culture, understand your unique struggles, and find somewhere you can relate to each other on a personal level as parents and people. Providers need to address their own biases to bridge gaps and build relationships. So very early on, we were grateful to the Parent Leader Brain Trust for helping us to really hone in on the incredible importance of thinking about equity in our work, and thinking about how important it is in order to be able to do really good strengths-based relational work, we must be thinking about our own biases and be thinking about addressing those biases, as well as thinking about the barriers to folks getting the resources and supports they need to support their family. And really thinking about that, how incredibly important humility and being a learner with families is in this work. Next slide. So now we want to take an opportunity for us to kind of dig into some examples from each of the three action areas. There's no way, we could go on for days about the amazing work that we observed out in the field. And so we actually, as a panel, had to really hone in on the examples that we could share. So we have much more that you can find in our report, but we wanted to highlight some that we thought provided good examples of really what we saw across the board. So starting with nurturing parents' competence and confidence, next slide. We often saw across all of the different visits that we did, providers, all members of the care team, really working within that visit to model activities that promote social emotional development and the parent-child relationship. And so often they would do this through bringing a book or a toy into the visit. And sometimes they would even use different sort of parts of the visit to be able to do this, but really using that book or that toy as an opportunity to use strengths-based observations, observe the parent and the child together, and join with them to play and learn about and be able to reflect on and observe those positive parent-child interactions, and doing that as a way to really strengthen the parent-child relationship and as a springboard for a way to share information about child development and relationships. It often was something that, the book or the toy could then be extended into a way to set goals with the family about how they might bring those different practices home with them. Or often we would see that the book could serve as an educational tool as it is. So we observed one provider bring in a book about social emotional development for a 2-year-old and her family, to be able to sort of start to talk about anticipate this new change for the child, and to talk with the family about possible strategies. We think this is a credible opportunity for equity as well, to use books and toys that display different cultures, so folks might learn about different cultures and different experiences as well. And finally, we saw some really innovative practices here, using video feedback to take a short video of the family and be able to observe and reflect with that parent about the interaction and how they are supporting their child's development in the parent-child relationship, as well as group well-child visits, where with a group of families, the provider and the care team has an opportunity to often observe for a full 2 hours as families play together, and be able to together reflect and observe and provide strengths-based feedback about what parents are doing with their child and how they're supporting their social emotional development. Next slide. The second one was we really saw many practices with a focus on being able to connect families to supports to promote social emotional development and address stressors when they arise. And so, next slide, Selena. This often started with screening for social emotional development, maternal depression, intimate partner violence, and concrete support needs. But from that, we noticed that sites were really focusing in on, once you have that workflow, to be able to implement those screeners with families and be able to use that screener in the visit and make those connections, being very intentional about the community partnerships that they're cultivating and curating. through very clear processes and protocols. So often we saw a staff person whose role was to track follow-up and to develop those relationships with community partnerships. So it might be a nurse that is very passionate about social justice and making community connections, who takes this on and uses 1 day a week to really do the follow-up and connect with resources and stay up to date. Or in communities that have a centralized resource and referral, like a Help Me Grow, that was an important resource for that provider to be able to connect with a one-stop shop. We also saw examples where clinics would attend, staff from the clinic might attend a monthly meeting where all the providers were there sharing resources, getting up to date, and maybe even doing some problem solving. And finally, in places that were really able to have sort of that centralized resource and referral and collect data, they were able to use the experiences from families to improve quality. So they would learn about wait times, learn about the cultural responsivity of a particular resource, and be able to provide feedback to that service as they're really trying to focus on community alignment. Next slide. And then lastly, we saw a real focus that to be able to do this, the clinic and the care team had to develop the infrastructure and culture amongst themselves to really support these innovations and good work. Next slide. And here it was hard to pick just one example, because we saw that these common practices that we observed really connected with one another. So oftentimes, I think a very common response that we heard on our site visits was that a provider cannot do this alone. And we almost across the board saw that care teams involve multiple different types of providers, whether it be community health workers, social workers, psychologists, community resource navigators, or legal partners. And we saw that very clearly, but what we thought was also incredibly important to raise up was for that care team to work well together. These sites really focused in on intentional structures that enhance the care team communication and collaboration. So they were really focusing in on how they worked together and how they collaborated. And what that might look like is in a couple of different places. That might be a case review where a group of multidisciplinary providers get together to discuss cases, support one another, problem solve, and work to really figure out how to support that family. Or it might be really thinking through the way that the team is going to communicate on a daily basis, maybe through a daily huddle, having a plan for when they'll be able to communicate prior to a particular family coming into the room, but really being thoughtful about how that works and continuously improving. I think secondly, these care teams also recognized that they were going to have to do ongoing learning and development, that in order to be able to provide resources around early childhood and social emotional development and social determinants of health, it was going to involve learning together, not only about those topic areas, but also how to work together as a team and continually to developing. And a real focus on things like relational practice, trauma-informed care, addressing bias, and community resources and supports. And finally, we really heard across the board how sites were very intentional and thoughtful about how they designed their environments to really promote relationships and the patient-family experience. And in these cases, that would look like the physical environment. So how does making sure that families are seeing themselves in the books, the visuals on the wall, as well as seeing people who look like them as part of the staff. Really being thoughtful about how everybody has a role to play in welcoming that family and building a relationship within them from day one. And lastly, one thing that struck me was even thinking about relationships when it came down to scheduling and to wait times, recognizing that in order to build a relationship with a family, we need to be able to get them in for all their well child visits and be able to have all those opportunities to be with a family, and being thoughtful that wait times were something that A family who might have a longer commute to get there, take 3 buses, or have a job where they can't take time off, that is something that could damage that very important relationship with a family that is necessary to promote the social emotional development of young kids. Next slide. So it was incredibly exciting to witness this amazing work and learn with such diverse communities across the country. It was such a privilege to go out there and learn from these folks. One other thing that we were able to learn from the family members on our brain trust, the sites, and the pediatricians was scaling these efforts is incredibly challenging. Having the common practices be universally accessible to families in pediatric practices. There are currently both systemic constraints and pediatric team readiness constraints that really limit that widespread implementation and adoption of the common practices. This is something that we're going to spend more time on in our next webinar next week, but we wanted to be sure to give a heads up that this was a real focus of our work was to try to uncover these systemic constraints and barriers. And I'm sure as no surprise to anybody on this call, a major one that came up over and over again was financing, time and money, as something that not only that time within the visit, but also the time and financing necessary for the other types of resources to support this work, things like books, or the time to be able to collaborate and cultivate those community partners or coordinate within your team. We also heard about data for learning and improvement, that data right now is not being used to really inform. There isn't a universally agreed upon set of metrics that help clinics and communities focus in and have that to be able to inform their clinical practice with families, but then also to be able to work towards quality improvement and population health. Over on the readiness side, one thing that we greatly valued in our work, but did not see often, was engagement of families in systems transformation and pediatric transformation, and really seeing that so much of this work is local and has to be adapted to the local context, and how incredibly important it is to have those local family partnerships so families are there in the systems design. Next slide, Selena. Our funders, the PSP consortium of funders, knew, just as all of you do, that financing was going to be a challenge. So we wanted to be sure to let you all know of another resource that exists. Last spring, Fostering Social Emotional Health for Pediatric Primary Care, a blueprint to leverage Medicaid and CHIP to finance change, was released and offers strategies for opportunities within Medicaid that can support many of the common practices. Right now, CSSP and Manat Health are working with 7 states over the next 6 months to really support them to test out some of these different strategies, and we will be sharing what we learned from those folks over the course of the winter. Next slide. And after looking at all of those common practices and thinking through the systemic constraints and barriers, we do raise up in our report several recommendations that we will also talk more about next week, really focusing in one thing that we think is incredibly important is this building a national leadership, and really focusing in there on making race equity explicit and bringing the provider and the parent perspective as central and in leading that change. And we are excited to be able to talk more about that with you next week. Next slide. But now I want to stop talking and invite our parent and provider to share some of their reflections from the work. And I really encourage everyone to go into the Q&A and share your questions along the way so that we might be able to have Casey and Kima respond. So Casey and Kima were both joined us on the site visits last year, and actually did some site visits together. So you have a great group here for their reflections, and we actually thought we would start there because parent engagement and provider engagement was so important to this work, those perspectives. We really wanted to hear from Casey and Kima about how it was for them to collaborate together in these visits. What was different about that experience, and how did it help your learning?
You want me to go first, Kima, or?
Sure.
Okay. So, I mean, again, Stephanie, Selena, thank you, and Family Voices, of course, for the opportunities for being a part of this project. It really was an amazing experience. And, just to get in reference to your question is, how was it collaborating together? I mean, it was great work, and it was really interesting because this is one of the rare occasions that other than I guess I would say an IEP meeting, right, for a child, one of those rare occasions where you would have this type of group collectively sit down and reflect on a professional level, right? So I think it made both myself as a parent as well as the physicians and those others that were involved really kind of think of how certain questions were addressed and, how we realized, what we didn't think about just kind of sitting in our own seats, right? So I remember when we were visiting the centering program, and I was just like, we were all for the project and the program was amazing to see, but one thing Kima kind of brought to the table was, wow, what happens with physician burnout? This is amazing, but does this really happen? Does it exist? And for me as a parent, I'm saying, what is physician burnout, right? Does it exist? Because as a parent, when we come to, a visit, we look to see what the information is needed, what we want, how can we get it, and really kind of don't say, let's look at the person that we're coming to see on this visit, meaning the physician, what they're going through, right? So these are real people as well, and we kind of need to set that apart. And then in addition to that is the relationships that we noticed on these site visits were phenomenal, from the relationships from the parents to the physicians, in addition to those that were the front people in the offices, right, that was doing the scheduling. And also in reference to centering was a community of parents that were coming in for those child well visits, and they begin to form relationships with each other, and then eventually that made better community outcomes. So it was just really something that we never really experienced together all the time.
Yeah, and I have to agree with everything that Casey said, but I also felt like, one, when hearing Casey ask questions, we went to a meeting, it just made me ask questions that I never would have thought of and take it to a next step that I think really gets to kind of that culturally effective care, because you're asking questions in a much deeper and much different way. And I think as a pediatrician, I think I became a better pediatrician when I became a mother, but even so, I could not have gone to those visits as a pediatrician mom combined, because when I go into a room with a patient, I'm a pediatrician first. It's just the way you're trained. And so it was incredibly valuable to have Casey there. And I think it was incredibly valuable to then that helps you understand why, when you're doing these collective practices, you really need that parent voice from the beginning, asking the questions that you need to have the answers to as you're creating, developing, implementing the program. And so it was absolutely fabulous, I have to say.
Thank you. And so digging into some of the practices that we've been talking about, how do you both see these practices enhancing pediatric primary care, and why is this transformation so important? And we did get a question that sort of connects to this about sort of the response from other providers, Kima, that you might be able to speak to, so others and other colleagues in your community and how they've sort of responded to what we uncovered through this project.
Sure. So how does it enhance pediatric primary care? I think it enhances it greatly. And tying back to what Casey was talking about in terms of burnout, it's a chance to kind of go back and remember why you wanted to become a pediatrician and have that ability. You have more time to sit and talk and get to know the families, more ability to be part of a team, and a team that serves the individuals, the parents, the babies, the parents, and the community as a whole. And that's why most of us went into pediatrics. And so I would say for the other pediatricians, they felt similarly. And I think part of the other beautiful part of it is it's not about volume. And I know people often say fee-for-service is about volume, but managed care is too. If you're getting a certain amount of money for each patient, you still have to get a certain amount of patients in the door. And this really was about outcomes and outputs, which people are like, well, then you're not seeing as many. But the difference, I would say, and it's something that gets to the second point, is the patients want to come. The parents want to come because they're sharing with each other, they're sharing with family. That kind of engagement leads to people actually coming in, retention of patients and providers, which, you know, if you're looking at the bottom line, as many of the insurance companies and bosses are, it means you have less turnover, less burnout. You're actually going to be able to hit a lot of your outcome metrics because people are coming back for all of their shots. And so I really do see it, recognizing that, you know, financing issues you brought up, and we'll talk about those next week, but it really does enhance pediatric care, and in the main, pediatricians like it. The only other thing I would add is the beauty of the team means that every single pediatrician does not have to be culturally effective for every single patient. And we have this ideal that I often go into, that every pediatrician is going to be humble enough and shut up enough and have a relationship enough that we can bond with every single patient, but that's not life. Whereas if you have a team, even if you can't, someone else can. And I think a lot of pediatricians appreciate that because someone else can have the bond and bring the information needed to really care for the family as a whole.
Thanks. Casey, do you want to share sort of how you see these practices enhancing pediatric primary care?
Right. So, I mean, absolutely. So it's really awesome to see that this always comes up, right? So these practices and the way we want to move forward comes up. So I've been, you know, able to be involved in medical home. I'm part of a Lynn Fellowship here in New Jersey at Rutgers University. I'm work on the Parents as Champions project here at SPAN, and it always comes back to the relationship, right? In addition to understanding that the parents now are very savvy, right? Parents are coming into offices as consumers, and they know what they want, right? So we've kind of passed that level of, I'm coming to the doctor to get the answers to the questions that I want, but you're not just going to give me a list of what you think I need, right? Parents are now in the position where they need to collaborate, and they're going to bring valuable information because they are the experts of their children, and they know that, and they want their voice to be heard. They want their physicians to not only know that information, but also use that information productively so they can have the best outcomes for their children. So that's why I see that this transformation will be very much important, and that we continue to kind of move forward on this avenue so that we can have these great turnouts with these physicians, parents, and ultimately the communities as a whole.
Can I just add something to that, Casey? The other thing.
Here we go.
I know, right? And so I must say it was actually awesome to be with Casey, and I found like a new best friend. But so I think the other really important thing is that part of what we found across the board is that positive, strength-based, honoring, and respectful relationship show the parents prove to be advocates in other areas of the life outside of this pediatric practice. And that is so important. If we're talking about social emotional learning for kids and their long-term trajectory, that advocacy is so important because it's not just a consumer at the pediatrics office, which is huge and important. Like, you unfortunately have to advocate and be a consumer at the educational level, at the, like, anywhere you go. And so any way we can foster those other skills, and these programs, because they also focused on the parents, really promoted that as well, which was amazing.
Yep.
Great. And so I want to just transition a little bit towards equity, because I think equity and culture came up a lot in all of our conversations, both with the family leaders and with the pediatricians, as we were thinking about this work and where we're headed. So I wanted you guys to reflect a little bit about why and how does this work? Does this work in terms of social emotional development and the parent-child relationship really need to start with equity? Who wants to go first?
I can go first.
Okay.
Right. So we can only kind of see this through our own lens and our own experiences first, right? And really kind of understand, where to start with our physicians and why it's so important. And I think, Stephanie, you and I have really kind of spoken about this before, just what we've gone through with our own kids, right? Mm-hmm. So, culturally walking in, just my own experience into a an emergency room, right? And my son is prone to asthma, and he does have autism, and he doesn't, although he's great in communication, he doesn't always communicate to the point where he can basically do that for himself. So obviously I am his biggest advocate, right? And I just felt like once I walked into the door, as scared as I was, not knowing that my son would be admitted into ICU, I was immediately targeted as being a mother that was not going to cooperate when they just did not want to listen. There was a lot of cultural bias, and I can't say that I was met at the door with the understanding or that equity, right? So when you and I begin to share stories, right? Stephanie had the same exact experience. Her son, was it very recently, or how long ago?
It was about a year and a half. We also were in a hospital setting for he had pneumonia, had to be admitted, and I was also advocating actually when again really wanted to bring him home, and was having these conversations. Heard later from my PCP that maybe they didn't agree with the fact that I wanted to bring him home, but did not receive the resistance at all that Casey received, and also didn't have to think about things, like didn't have to think about how I might be received in that moment and how I needed to think about my communication. None of those things. I could just focus on my son and what was happening in that moment. And I think when we were able to share those experiences, it was a real aha
it's a very huge aha moment, right? So Stephanie was able to raise the exact amount of craziness over her child that I did, but I was looked at as the mother who, like I said, was the angry Black mom that was not cooperative, that did not want to listen. Both of us very, educated women with children, and we just want the best outcome. Both of our children had the same diagnosis, but I was threatened with child services and not participating and not wanting to work with the team, when the only thing that I was actually trying to do was actually explain to them that my son did have autism. He was prone to asthma. We did not know at the time that he had pneumonia, but the normal practice he would get a shot of prednisone, we'd be there for a few hours, he'd go home, right? But none of that would work. I had a care plan, I have a coping plan. No one wanted to listen to anything I had to say. It wasn't until I began to now put on the professional hat and, wave around my, ID that I worked for a hospital at the time, that I was an advocate, that I did work for the Division of Developmental Disabilities, and I did have a lot of information, and I knew who I needed to talk to, and what I said mattered, was then when I started to get a little bit more of cooperation, and that should not happen.
And I think what that big aha is that in order to do this strengths-based work, we have to start with equity, because these biases exist in terms of who has strengths. How do we approach families? Kim, I wondered what you want to reflect on.
Sure. I guess I would say two parts that lead to that. One is that even before I had kids, I realized when someone comes to the office, this is their most precious being in the world, right? And as such, you are incredibly vulnerable. And in the outside world, many of us just get trampled over and over again. And now this is the space where you need some safety, because you're taking care of the most important thing of your life. And the only way that a pediatrician or a clinic can engage in that is to hear that vulnerability, work with it, build on it, and provide the strength for you to step out and keep going. And it doesn't look the same for everyone, and it shouldn't look the same for everyone. It's a different language, it's a different trauma informed, all these pieces are different, but you have to listen to, because if you don't listen to, you're not going to get the outcomes that in the main every pediatrician, every mom, every family wants to see. So unless you start with a recognition that you have to be humble and listen, it's not going to work. I think the other piece I'd like to say for that is equity is a two-piece sword. I kind of alluded to it before, but I have a lot of resistance to the idea of cultural competence because I don't think we're going to be competent. What we need to provide is culturally effective and responsive services, and really just be humble enough to listen to the parents and the families and what they need, and be able to take that listening and try to engage and tie them to another service as needed that's culturally effective. And that takes a lot of training and humility, which frankly you don't get in medical school. Frankly, I don't think we get in life in stop period at school or anywhere else, but I think that's also the value of a care-based team, because there's sometimes you're going to have a bad day, someone else is going to have a bad day, but to have someone else who can do that, and the importance then of having a team that is diverse, that's that can represent, understand, willing to work with, and understand community is going to be very important. So it's not just having a team, it's also the team that you pick from the beginning that's going to bring about that equity in the long run.
And I think, you know, that was one thing that we definitely seen when we went to the site visits, right? The equity was there, it was inclusive, it was culturally unbiased, if you want to say that, right? So, you know, when you're talking about the centering, these parents came in every 6 months, was it, Kima? Every 6 months for their child well visits. And by the end of the 18-month term, the parents did not want to leave. They wanted to continue the program, right? So they wanted to continue the group. I mean, like, so let's think about what we've seen, right? We've seen children growing up together. We've seen social and emotional relationships. We've also seen parents, right, become connected, right? Mm-hmm. We also were able to take part of a grandmother that was also involved, right? So now we're bringing families within the aspect. We also seen physicians learn from the parents, mm-hmm. right? And then we also was able to locate and really speak with that community navigator who was also a part of the program that was relative and could relate to the families, they could relate to the physicians, and also outside in the community. So if there was a referral that was given to the parents, it was a warm referral. Yep. The parents weren't walking somewhere else with their eyes wide shut and had no clue where they were going after they left the physician's office. And what they did at the end of that 18 months was they formed their own groups, right? They formed their own group outside of the community so they can continue on. I mean, there was one family that I remember, she was so embedded into this program that she took 2 buses to get there to Philadelphia. Right? She took 2 buses, and then you had other families that referred their family members. So someone had taken part of it 18 months and then referred her sister. You had families that were coming over from centering pregnancy to centering parenting. It was just amazing. It really was. Same thing with Reach Out and Read. We've seen the same outcomes as well.
Yeah,
and I think sorry.
So I want to also just remind folks that we have time for some questions. So if folks want to enter questions in, and just want to say that the enthusiasm and passion that Kima and Casey are expressing, and the amazing work that we saw across the country, there were these that's how it became. We were able to really identify those 14 practices, but because you can see that these folks are really coming into what is really needed to support families around social emotional development and the parent-child relationship. So while we wait for some questions, we did have a couple of, Kima, did you want to say something? And
I just want to say one thing that's actually stolen from Selena. But she's not saying it, so I am. But one other thing she said, which I thought was incredible, a lot of these hospitals and groups did not originally have quality relationships with communities. But by bringing these holistic practices that patients wanted to engage in, they were repairing relationships with entire communities. And I think that also is important. It's not, again, just about what happens inside those walls. It's transformative for communities often.
Yeah.
Mm-hmm. Yeah, we heard that more than once about that experience. So far we've gotten some feedback where folks are really resonating with the experiences that people are sharing. Julie shared that she's reflecting on an own experience that she's had with her son when he was diagnosed, and feeling unsupported when she received that diagnosis, and how really important much of what you're talking about makes a difference. Thank you so much for sharing your experience, Julie. And then also hearing from I hope I am saying your name correctly, Fazia Escu, about an experience that she also had with her young child and being brought a Spanish-speaking interpreter because of an assumption that was made when she is Pakistani, and how that impacted her. So just, it's really helpful. It's really wonderful to hear that. We really thank you for sharing those experiences and hearing that things are really resonating for folks. Please let us know if you have any questions about some of the things that we learned.
I can share the past ones too that we asked. And also, Stephanie Fajia also just included that a mom was having challenges at the front with the front staff because there was a wait time, but the pediatrician came out and asked what the issue was, and the mom was concerned about losing her spot at the local homeless shelter. So yes, just being really, thank you for sharing that, Fazia. And yeah, going back to the point of really thinking about there's other things going on in families and parents' lives. We got a couple of questions, but fairly simple. Will we be sharing the PowerPoint? Yes, we will be sharing the PowerPoint and the recording after this. And a question kind of about how we shared our findings and our recommendations. Have you been able to discuss your findings with other providers? If so, how receptive are they to these recommendations? And that is from Alex Cambreros. And we answered it, and we were able to discuss our findings with other providers. For example, we had the provider consultants. So there was a group of them, 5, including Kima, who attended these site visits around the country, but we also consulted with them throughout the entire process about even choosing them, but also at the end of them when we were talking about our findings, they were really even driving some of that and having critical discussions with them, and then sharing what their thoughts were about what we learned on these site visits. And then not only them, but we had stakeholder conversations with the AAP and other groups. And we also shared our findings with the program developers as well as the local staff who we were working with. And that included providers when we were developing the report. And then after the report came out, we have been able to attend a couple of convenings and share the information, what we learned from the site visits. And they have given us their thoughts as well, and they have been very receptive and open to these ideas and the common practices, but also, of course, recognizing those core barriers that we talked about, and we will discuss more next week.
I think what I'll just add to what Selena's saying is I think that's been one of the most amazing aspects of the project was, and a little surprising about the sort of, I don't want to use the kind of like consensus. There's been sort of like a general, people have a general sense and are working from the sort of same foundational values and approaches when they're doing this work, when they're really trying to focus on the outcomes of parent-child relationship and social emotional development and addressing stressors and concrete supports for families. It's amazing that while some of the tactics might be different, like so some folks might do a group well visit, others might do video feedback, others might do reach out and read. Many of these places are bringing all those programs together. It was rare that we went somewhere and we didn't see multiple things happening. So it was amazing, the sort of consensus that was developing of people are figuring out how to really serve families well and coming up with very similar solutions that might look different based on their context to really meet the context of their community, but have similar sort of underpinnings of what they're trying to achieve. So it was really gratifying. We also had a chance to visit places that were doing sort of more collaborative. We visited South Carolina and had a chance to visit a group of several practices that were working together in a network. And again, very amazing how across those 30 practices in South Carolina, they were really sharing and learning from one another some similar practices and approaches. we have one other question in the chat from Fazia about the strengthening families protective factors. And we did see that many places were focusing in on those protective factors. One of the and would talk about them when they were thinking about their work. So it really was an under foundation to it. For example, we visited Promoting First Relationships, which is a training program developed in Washington State, and they actually include in their residency training talking about the strengthening families protective factors. I also just noticed, and we have a few minutes left, so I'll talk Deanne Davies, I had the great pleasure of visiting Deanne in Show Low, Arizona, to their Healthy Step site at Summit Healthcare. That was amazing. And she wanted to add that rural communities without resources and many gaps need to create innovative approaches and rely on community partners to fill those gaps. And that was exactly what we saw in Show Low, but then in a rural community, but then would see how folks are doing that in other places where they brought that program in, but it really unearthed all kinds of gaps in their community, and folks, implementers on the ground, are working really hard to fill those gaps and figure out how to meet families' needs. And it was inspiring to see. It was surprising that how often we heard the phrase, "We're putting the pieces together." We're one piece of the puzzle and we're putting those pieces together over and over again, no matter where we went. So this has been a fast hour for us. I hope it has been for you, and that you've learned a lot, and we've sort of brought you some different ideas and different approaches that you could possibly take home with you. Go to the next slide. To close out, like I said earlier, we really focused on those practices in this webinar, but we definitely recognize the systemic constraints and barriers that are impacting the ability to promote those more universally across the country. And so next week, on Thursday at 1 p.m. Eastern, we will be diving more into those constraints and barriers and really talking through the different recommendations that we, along with our stakeholders, have put together. And so we will get these slides and recording out to you by tomorrow so that you have them with you, and we really hope that you can join us next week for the next the webinar. So thank you so much to Kima and Casey for your reflections and insights, and to everyone else for listening in and learning with us. Thank you.
Thank you. Bye-bye.
Bye.